So today, the webinar is centered around musculoskeletal ultrasound. What a great tool MSK Ultrasound can be when used in the right hands with the right machine. And we have two top-notch MSK radiologists with us today to throw some lights on deep insights into MSK Ultrasound. The first speaker for today is Dr. Girish Gandikota, and the second speaker for today we have Dr. Elena Drakonaki. Dr. Girish is an eminent MSK radiologist who is a professor of radiology and vice chairperson of radiology at University of North Carolina, USA. And he has been one of the founding persons of International Muscular Summit. He is an expert in MSK ultrasound, MSK MRI, musculoskeletal interventions, and I'm sure most of you already know him. So we'll not waste much of time, and we will be starting with the first lecture for today, which is top clinical indications of musculoskeletal ultrasound, where ultrasound is absolutely the king and you do not need any other imaging modality to make and confirm the diagnosis and to go ahead with your management for those particular conditions. So over to Dr. Girish.
All right, Gaurav, thank you so much. This is, and it's a pleasure to see you all. I hope you can see my screen, and I will start off. My intention is really to spice it up a little bit about what is to come. When we meet in Mauritius, we're going to discuss in detail about everything that I'm going to talk about today. You're just going to see the snippets of it, but they will be useful to you. I have no disclosures. And we will be reviewing some of these conditions where we think ultrasound is a better tool to apply when compared to MRI. So why MSK ultrasound is always a question, and I always show this particular cartoon, and it says, sometimes MRI can be an overkill. You really don't want to dress up like that and do all that stuff to catch a chicken. So if it is a focal problem that you can see well on ultrasound, you don't need MRI, you don't need wait times, you don't need an extensive imaging investigation. Also, MRI gives you a global perspective, right? It looks like this couple is happily getting married, but when you look at the ultrasound and you try and focus it a little bit, and now we have got better machines, so you don't even have this bad resolution anymore, it says, help me. So you may be able to get the real picture on ultrasound compared to the MRI, right? But you know what? I do both, and I use both, and I'm not biased to any one particular imaging modality, but I'm only going to highlight the things to you which can be done cheaply, fast, in an efficient manner, and stuff that is going to mean that you don't need MRI again. Now, in terms of where we were and where we have been, I will show you some images where we were about 10, 15 years ago. But right now, the image clarity is so much more that one would even question whether we probably are seeing much better anatomical detail on ultrasound compared to some of the MR imaging that we get. And MR imaging is so very dependent on the technologist, the MR scanner, the way we scan, the patient, the movement, and so on. Whereas this, you can control most things yourself. Here is an example of fibrocartilaginous attachment of the supraspinatus. Now, here is the fibrocartilage. Here is the articular cartilage, which is the hyaline articular cartilage. You can see it here. And then when you look at the video, I don't know if you can see the video running, Gaurav. Let me know if you can see the video. But here is the avulsion.
Video is playing.
Oh, thank you. Avulsion of fibrocartilage and the rotator cuff. So you are now seeing details not just of the tear, but even of the fibrocartilage and so on. So this helps us with gout. This helps us with so many other things that we initially had issues diagnosing. So that's very nice. The other thing is about the smaller nerves that we can actually see. We all saw median nerve with relative comfort, right? But with the newer machines, here is the palmar cutaneous branch of the median nerve that you see next to the median nerve, deep to the flexor carpi radialis. And this is the nerve that you want to avoid while doing any kind of interventions. So here, I don't know if you can see that, but there is the nerve. and that comes out here, and that stays, and there is the nerve again, and I can follow that through. Now, in Zoom screen and your smaller screens, you may not be able to see this, but we will demonstrate this when we meet back in Mauritius, how easy it is nowadays with some of our machines, newer machines, to look at these smaller nerves like the palmar cutaneous branch, which is very important when you're trying to do the interventions. So in terms of ultrasound is the king, I had to stop here, but there are more. And I had to put in broader things like interventions. And in the interventions, there are so many impingements, there are so many. So anytime there is an impingement, I take ultrasound. Anytime there is an entrapment, and even for carpal tunnel, I would like to do ultrasound. Any subluxation of issues, whether it is tendons or ligaments, I like to do ultrasound. Gout, yes. Synovitis versus joint effusion versus enthesitis, and I will show you some examples. Again, ultrasound. Any foreign bodies which is not glass, like wood, which is not seen on X-ray, ultrasound again. Any mass lesions like ganglion, I would like to do ultrasound so that that is it. We don't need to do any more. And scanning around the hardware, and that's a huge big deal. Any hardware, anywhere, the patient first comes to ultrasound. And a lot of nerve lesions, I feel better with the ultrasound because you can follow them better. High resolution images demonstrate better, right? So these are the 10 places where if somebody were to come to me, they go straight to ultrasound. They usually do not go to MR after that. So in terms of MSK interventions, we will have a dedicated lecture very soon. So I will not go too detailed into that. But there are tons of MSK ultrasounds that we will be talking about in our Mauritius program, and we will go in detail in that time because we have a lot more time then, but a lot can be done via ultrasound. This is a 58-year-old man with severe shoulder pain, limitation of movement, rotator cuff tendinosis. Yes, there is tendinosis here in the supraspinatus, but the bursa was injected, and there is the injection of the bursa. The bursa itself was not very thick, by the way, but the patient had a lot of pain, so we did inject the bursa, and the pain did disappear. So one or two things here. This cannot be achieved clinically without ultrasound. Of course, it cannot be done on MR, but it is one of those places where it is like the extension of a diagnostic capability. You're doing a diagnosis, you feel like there is impingement, you want to inject, you can. In some countries, you will need a requisition. In some places, you may not, depending upon your situation. But it is such an easy tool to have and continue to do. Here is an example of tendinosis, tennis elbow. And here is an example of tendon fenestration that you can do once we have tried all the conservative measures and it is not improving. And Gaurav is going to talk more about that in the next webinar. Here is another example of a hamstring tear and tendinosis. The surgeons don't want to get in here because it creates a lot of scarring, and this is the sciatic nerve, and they do not want more scarring near the sciatic nerve. So they ask us to see if they can aspirate, and we can do a little bit of fenestration and a little bit of rebleeding so that it can heal better. But these are places where, hands down, there's only one option. Sometimes you have pain along the lateral aspect of the hip, but you scan the patient higher up and you'll see the iliotibial band thickened at the iliac crest region. This can not only be identified on ultrasound because now you're targeting and going up way beyond where the pain is. Sometimes in MR, you may not even get to that level in the visual planes. And then you identify this, and then you can target this based on tendon fenestration or and make it feel better for the patient. Here's another example where you can identify a ganglion cyst in the MRI. But yes, of course, you put a needle in and aspirate from the cyst in this particular location through ultrasound. You also have to make sure that you fenestrate the cyst because these things are very thick, viscous fluid. You normally don't get much out. But if you make the holes around the cyst, they usually disappear, and the body takes care of it. Moving on to impingement. Now, there are a lot of impingement things that you do on ultrasound, right? This is a 45-year-old patient complains of pain and limited movement. So I just wanted to say the dynamic evaluation, there is no way we'll get any of this done by the MR. So this is for impingement of the shoulder. That is the movement you get. And that is how it will clearly disappear. The humerus will clearly disappear deep to the acromion. There is no bursal pooling. If there is an impingement, you will notice that there will be pooling of the bursa that you see here at the fine point of it disappearing deep to the acromion. So this is a good example where a dynamic evaluation helps you confirm the diagnosis. Here's another example of calcific tendinosis, which is actually decent on MRI. You see the edema as well. You see now the calcific tendinosis within the supraspinatus tendon. Here is a needle going into that. Are you able to see the videos?
Yes, they are.
Okay. Yeah, they're not very clear, but I will tell you the point which I was trying to highlight is, when you put this in and you aspirate, and this is how the fish mouth appearance happens. You're trying to aspirate all the calcium. And again, we'll talk more about this with better videos next webinar. But the point here was, before aspirating, that is the calcium, that is the acromion, that's the greater trochanter, and you try and see if you can lift the hand, the calcium will not pass through. It was significantly limiting the shoulder movement. Now, when you look at this, after we aspirated the calcium, it still looks the same outside because the outside shell was very strong. We took a lot of calcium out, and when you then ask them to do the abduction movement, it disappears because it is soft and supple and going down. So you immediately get the feel that you did take a lot of calcium out. The patient feels better. You will obviously inject a little bit of steroids in the bursa so that they don't get the pain back. But you not only are diagnosing a problem, you're treating a problem, and then you're looking at the effects of the treatment with the help of dynamic ultrasound. Snapping hip is another thing. Like, for example, if somebody comes with snapping hips, again, how does the ultrasound help? Maybe not. Here is the probe position. That is the iliopsoas muscle. That is the tendon, iliopsoas muscle and tendon. And while the scan is a little spotty, but you will see the tendon falling off on the pubic bone, and it actually flips on itself within the iliacus muscle. And if you see that, and if there is pain, then you can put a needle in and inject if that's what the clinician wants, and you will see the tendon and coming up. And that is when you know that you're in the right spot, because if the tendon doesn't come up, you may be injecting in the joint. And again, more of these points later on. Here is an example of snapping iliotibial band. And again, you see this. There it is. This snapping comes on top of the greater tuberosity. And that, again, is something that you can diagnose with ultrasound. Moving on to dynamic evaluation, tear characterization and retraction. This is also, I prefer ultrasound because, say, for example, there is an Achilles tendon tear. They want to know at what stage are they coming together, 20 degrees plantar flexion, dorsiflexion, what is it, how much? And so that they can immobilize the tendon when they are in contact, and therefore it helps them a big deal. So this is an Achilles tendon tear with Kager's fat pad coming in between. Then you look at it, this dynamic evaluation, you will know how far they go and how far they come back, and then you can give them the degrees of plantar flexion needed for the tendon to be approximating to each other. So that's a very positive information that you get from ultrasound. So all Achilles tendon tears, you will go down the path of ultrasound. Now, MR is good. About 80 to 90% of us in the US only do MRI, and that is also okay. But this will give a little bit more information, so why not? Here is another example of how the ultrasound can help with dynamic evaluation and assessment of a ligament. Here is a normal ulnar collateral ligament extending from sublime tubercle to the epicondyle of the humerus. This is the flexor attachment overlying it. So in thrower, right, in 16-year-old baseball pitcher or anybody who throws, probably cricket as well, if you have a pain medial elbow, you want to know whether this ulnar collateral ligament is keeping the sublime tubercle close, and that is, in other words, the ulna in close proximity to the humerus. And the way you assess that is by giving a valgus strain. So you strain the valgus, the elbow in a valgus fashion, and then you can ask them to move this. And there is a little bit of widening at this location, suggesting that even though the UCL was looking okay, functionally it is not okay because it is wide at the joint space, which is not, it should not happen that way if it was a normal and intact tendon. So again, a dynamic evaluation, very, very helpful. There are other ligaments, and again, a lot of this we will discuss in detail when we meet in Mauritius, is how do we assess these ligaments best, right? For example, this is the calcaneofibular ligament. In a neutral position, this is the dorsiflexion, plantar flexion, neutral position. I will show you. This is fine, but when you dorsiflex it, you will see this tendon, this ligament much better. Here is an abnormal calcaneofibular ligament, but you have to dorsiflex it to see the ligament much better. Similar is the case, this is the picture from the web, but similar is the case with anterior talofibular ligament, and we'll talk about the two bands of this later on, but this also will be stretched with plantar flexion. So you have to do a bit of plantar flexion and you can see this ligament much better. So you don't have to struggle looking at this part of the ligament compared to this. So again, these are all some practical tips, but these are only possible on ultrasound evaluation. In terms of entrapment, I like this very much for any nerves or even tendons where they happen. This is the assessment for carpal tunnel. You will assess at the distal skin crease, which is where the probe is, and then you will assess proximally overlying the pronator quadratus, proximal 1/3. The median nerve, as with any anatomical structure, when they're heading down, they should get smaller and smaller and smaller. If the median nerve gets bigger and bigger, then there is a problem, and that can be so easily assessed on this because you do get some high resolution images. So you will scan from here to there, and if the cross-sectional diameter of the median nerve is increased by 2 millimeters square at this level compared to this level, then you're thinking carpal tunnel syndrome. You measure the maximum diameter of the median nerve, which is usually proximal to the carpal tunnel. The distal end of the carpal tunnel is this line, and then the carpal tunnel is actually lying in this particular location. So this and this is here. So for example, that is the measurement that I talked about. If you have a bifid median nerve, then it is 4 millimeters square. We can talk more about this later on, but I just wanted to show you some examples. So this is at the pronator quadratus. This has become very big at the level of the carpal tunnel. It should be smaller than what it was at the pronator quadratus. So this itself tells me that there's something not right here. The cross-sectional area here is 0.79. The cross-sectional area here is 0.161. It is much more than 2 millimeters square, which is allowed at the max, and therefore this will qualify for carpal tunnel syndrome. And here is another example of where you can follow this. Here it is, and it can go down and then it becomes smaller. So if you look at that, it gets way too big and then small again under the carpal tunnel. So smaller pronator quadratus gets bigger and then smaller too. So it's one of those things that you can assess very easily. Here is another example of a smaller ulnar nerve, the median nerve and the pronator quadratus, much bigger, thicker, bifid type appearance of the median nerve just proximal to the carpal tunnel. So if you look at this, and here is it's coming up, and there it is. And then it gets really flat under the carpal tunnel. So you get a very dynamic assessment of that. And then, of course, there is a patient in front of you. You can talk to the patient. Where are the pains? What kind of symptoms? So it helps you with much more confidence with this carpal tunnel too. Here is a nice example of palmaris longus scarring and everything else getting involved, and median nerve getting involved in that. So a lot more clarity in the current MSK world in terms of what part of the median nerve is involved with scarring, how much of mobility is there, and so on. So we can assess all those in detail. And again, remember, this is the carpal tunnel injections that we do, and when we do the carpal tunnel injections, we will okay, we will try and avoid the palmar-cutaneous branch of the median nerve, and I tried and showed that to you, right? I mean, here is the same thing that you will identify here. It comes down here, there it is, next between the median nerve and the flexor carpi radialis. So try and go down here if you have to, but then you have to avoid the ulnar nerve and ulnar artery as well. Here is the example of a recurrent motor branch of the median nerve called the $1,000,000 nerve, which lives in the thenar aspect of the hand. And I don't know if you can see it, but this is the nerve, the branch of the median nerve that goes up and down. And again, thanks to the advancement and the resolution of ultrasound, we can see all this and guide our interventions based on these things. Here is an example of ultrasound guided median nerve injections, which we will talk about later. In terms of subluxation, we all know that the tendon subluxation can be easily assessed on ultrasound, like the peroneus longus and brevis. Here is an example of peroneus longus muscle, peroneus longus tendon, and peroneus brevis tendon. Here is an example of very thickened retinaculum, peroneal retinaculum on top of peroneus brevis and longus, right? And then so this is what's called intersheath subluxation. So it is subluxing within the thing, but the retinaculum is not torn. It's abnormal, but not torn. Here is an example of tear of the peroneal retinaculum and extension of the peroneus brevis overlying the lateral lateral malleolus. So this one is something that you can identify again on ultrasound quite easily. Like, is this just an intersheath subluxation or is it going out? At this stage, you have to repair the peroneal retinaculum. Here, you may just be able to put a suture anchor or rest, and there may be a place for conservative management at this level. Quite often, though, intersheath subluxations are not usually symptomatic. This is a 45-year-old radiologist with tingling in the 5th digit. And then, if you look at the ulnar nerve dynamic evaluation, this is how you will do it. And again, these are some things that we can only do on ultrasound. And why are you doing the dynamic evaluation? When you're trying to see if the ulnar nerve stays in the cubital tunnel and does not actually jump over the medial epicondyle. So here is the example where, this is the ulnar nerve and it just comes up till here. It doesn't go beyond. And this is the medial belly of the triceps, muscle belly. So it is fine, but it has not crossed over. And that is how these things should behave. But here, for example, if you look, that's the ulnar nerve, that's the medial head of the triceps, that's the epicondyle, medial epicondyle. And then when you do the same elbow flexion extension movements, you will slowly see that not only does the ulnar nerve go on top, you will also see the medial belly of the triceps also go on top of the medial epicondyle. So this is not only a subluxation of the ulnar nerve, it's called snapping triceps syndrome. So, and all of these things are such a dynamic assessment that you need a good ultrasound and sometimes a good technique as well. And then it'll go down this path. One of the caveats that you want to be sure and careful about is to not press too hard with your ultrasound probe over the medial epicondyle. Here is an example of anconeus epitrochlearis, very clearly seen. This is the ulnar nerve, and this is the muscle that starts from the fascia and finishes off in the fascia in the same level, and it is at this location. And it's it's easily identifiable. But even just having that muscle can sometimes make the nerve very thick, and it is one of those things that you want to look for and mention in your reports. Moving on to another indication where I use ultrasound, and this is the reason. If I see joint effusion, snowstorm appearance, erosions next to an echogenic tophus, and a double contour sign, I'm 97% confident, pretty much confident that we are dealing with gout. And I'm not saying that, it's from the paper. So you have to look for joint effusion. Now, sometimes joint effusion on its own is very non-specific. So at this stage, all you're saying is there's joint effusion. It could be infection, inflammation, or even post-traumatic if there is a history of trauma. Once you start talking about snowstorm appearance, we're talking about this echogenic microtophi that you see here. These are the echogenic microtophi that you see. And these are the echogenic microtophi that you see within the patellar tendon in this particular case. These are not calcifications. These are aggregations of microtophi that you see again in the distal quadriceps tendon. And these are not the calcifications. So when you look at this, and it is moving. So when you do dynamic evaluations, you will see the movement within the tendon. Now, very easily, you could avoid that and say calcification. So unless you know that these things can move, and unless you know that you can do dynamic evaluation, you can miss these things. And then, you can aspirate that, and that turned out to be gout. Now, in gout, the synovitis is very echogenic generally, not just gout, any crystal deposition disease. So it'll be an echogenic synovitis, and then you will have a little bit of microtophi floating around everywhere else. So that also helps me diagnose crystal deposition disease on ultrasound. And then, of course, there is this erosion with microtophi and echogenic synovium. All of this together makes me think again, I'm dealing with gout and not necessarily rheumatoid or anything else. Here is an example of a double contour sign in monosodium urate crystal deposition. Here, there is nothing. That is how it should be. It is a normal looking cartilage. And then when you look at this, you will see the cartilage lined up with a very thin, irregular deposits of monosodium urate crystals, which will look like a double contour. This is the single one contour. This is the another contour. So when I start seeing double contour throughout its length, and I'm not going to go into the cartilage interface sign today for lack of time, but if I'm convinced that I'm seeing a double contour sign, an echogenic tophus with microtophi, and an erosive change with small joint effusion, I'm thinking gout. So those are the reasons why I prefer that. Now, you can always do dual energy CT to confirm if there are big gout tophus, but that is not necessary. This is the gout bursitis, and again, the giveaway are these small little microtophi that you see within the gout. So moving on, I think my time may be running out, but synovitis, effusion, and enthesitis, right? So this is always a problem. In MR, if you don't give contrast, then you have an issue. Like, how do I tell the difference? Ultrasound, yes, power Doppler, right, or color Doppler. 53-year-old patient complaining of shoulder pain, rule out joint effusion. This is, the patient is here, and then if you were to scan, then you will see the fluid disappearing, reappearing, compressing. So all those are features of just joint effusion. There's not a lot of synovial thickening there. Here is a 30-year-old rheumatoid arthritis patient with shoulder pain. So here, again, you have your probe positioned at this location. So when you're applying pressure and it is not disappearing, that is bursal thickening, not necessarily fluid. That means something different. You can always have some amount of fluid, and that may mean nothing. But once you start having bursal thickening, you need to think about impingement. You need to think about RAing the right patients and right clinical setup. Here is another example of thickened synovium, easily giving you the availability of bursal thickening. MR, it will be bright. It is possible to tell the difference between the two, but not always, depending upon the type of MRs you have. Here is the example of thickened synovium. Now, synovium is hypoechoic, but there is some echogenic material within it, so you can talk about synovial proliferation. Here is also synovial proliferation, not necessarily too much acoustic enhancement to suggest fluid, but there is erosive change here as well. So together, this will be synovitis and erosive change. And then, of course, always you can use Doppler, color, or power to confirm increased vascularity. If you have increased vascularity, you will call it synovial synovitis. If you cannot pick up increased vascularity despite the best machines that you have, you may call it synovial hypertrophy or proliferation. So that is just a terminology difference, which most likely is defined by where you practice. Here is another example of tenosynovitis demonstrating increased vascularity, and quite easy to identify on ultrasound and MR. May or may not be, because they both will be bright, the fluid and the synovium, unless you give contrast. And here you don't have to. The other thing which ultrasound is really good at is identifying where this increased vascularity is so that you can say, hey, is this synovitis or is this enthesitis? And remember, enthesitis is on its way up, and it's a very hot topic in terms of diagnosing things, which we have missed for a period of time. But this is an example of increased vascularity in the, okay, maybe this one will work, yeah. Increased vascularity in the deltoid ligament, but you can see that next to that, at the bony attachment site, it's irregular, and the vascularity extends all the way to its attachment site. There was no history of trauma, there was no history of twisting, and patient, they were suspecting enthesitis there. Here is another example of what you will look like in an MCP joint, like though there is some soft tissue thickening here, so maybe this is all synovitis. But if you look very carefully where the vascularity is, the vascularity is all at the capsular attachment site. It's really that which is thickened. The bone is also very irregular. So you don't overdiagnose synovitis here, you diagnose enthesitis. And these are some things that quite easy to do on ultrasound as long as you have the right setup, right machine, and a picture which is enlarged so that you can identify. And more importantly, you know what you're trying to look. You're not trying to put it all together as synovitis. You're questioning yourself. Is there enthesitis as well or not? Is there gout there or not? Is it echogenic synovium or not? Is that double contrasign or not? So once you start thinking that way, ultrasound becomes a very good tool for you to keep going. And then I think I'm almost all finished very soon. So scanning around the hardware, you really have no other choice. This is another nice example of a screw that's coming out and causing irritation to the digitorum tendons here in this area, and then that was causing tenosynovitis. So they took the screw out. Similarly, this is another screw from the femoral fixation that was hitting the gluteal tendons and the iliotibial band, and that was removed as well. And here is another example. Post-op is very difficult. You have all this extra dark stuff that you see in the MR. You cannot identify whether there's a re-tear or not. But with ultrasound, all you're looking for is an empty trough, and there are no hardware artifacts the way you see in MR. So this was a re-tear of the rotator cuff, which is very easy to identify on ultrasound when compared to MRI, and that is why we look at. Of course, if you had done X-rays in the first, then you did not need both because the suture anchor was out. But how many of us are doing X-rays before we get to this thing? Well, that's the problem. And here is the acetabular component hitting the iliopsoas tendon, causing impingement. So that is also important. This is the normal iliopsoas tendon with the bursa on top. Somebody tried to do an MRI for a knee arthroplasty. Patient was having impingement symptoms. It's much better to do an ultrasound. All the tendons are thickened, which is quite normal post-arthroplasty, but there was also impingement of the medial collateral ligament adjacent to the hardware. Patient was focally tender there. Much, much better study to use ultrasound. In terms of ganglion, you're dealing with a ganglion. It is septated, it is lobulated, and there is a lot of posterior acoustic enhancement. In this case, it is next to an intact scaphoid ligament. So that is it. And then foreign bodies, it's probably the last one of mine. I will finish it off. Glass is seen in X-ray. So you should always X-ray any foreign body. If it's glass, it's down. You will see it. Any type of glass, you should see it. But if it's wood, you won't. And the more likely it stays, the more likely it's going to create this hypoecho exchange with this echogenic thing. So you want to do ultrasound to evaluate for foreign bodies. And don't think that it is easy to remember, take this out, because these will break once you're trying to take out. In terms of nerve anatomy, this is my last slide. See how nicely you can move the probe and continue following, say, posterior interosseous nerve in this case. Now I come down here. Here is the radial nerve. There is the branch going in the posterior interosseous nerve between the supinators and go on. So no doubt that you can follow these so far. So I was trying to show you some of these examples. We'll go very much in detail later on in our course, but all the interventions, impingements, entrapments, subluxations, inflammatory arthritis like gout, synovitis, joint effusion or enthesitis, any foreign bodies which is not glass, superficial soft tissue masses, scanning around the hardware. Everything else, I would choose ultrasound. So, so one thing though, it is true that when people start earning a lot, they will employ somebody else. But please don't do this because you will lose your skills. So it doesn't matter how busy you are. If you continue to scan ultrasound, you will continue to do better. Thank you and good luck.
Thank you, Professor Girish, for such an excellent talk. Uh, I think the message was absolutely loud and clear. So, to summarize, any structure which you can see in entirety, any extra-articular structure which you can see in entirety on ultrasound, then ultrasound is the imaging modality of choice. If you can only see a part of it or you can't see any of it, then obviously MRI is the imaging modality of choice. One very simple rule. And the spatial resolution ultrasound is beyond even research-based 7 Tesla MRI. And as the MRI will evolve, the ultrasound will keep on evolving even further. So I don't see MRI ever catching up on the spatial resolution ultrasound. And I think the most important message what Dr. Girish gave here is that he's not advocating ultrasound or he's not advocating MRI. We should all know what is the role of ultrasound and we should all know what is the role of MRI. And if we know both, then we will be able to do real justice to the patients. Thank you for such a great talk. We have a couple of questions here. We'll take them and then we'll move on to Dr. Elena. So the question is, can every shoulder effusion be tapped for diagnostic purposes? If yes, which test can be sent?
So the answer is yes, any shoulder effusion can be tapped. The question though is, what are you suspecting and why you want to tap it? And if you are worried about infection, you will send it for culture and microbiology and so on. If you're worried about crystals, then you will not send it in formalin, but you will send it for crystal evaluation. Yeah. So it depends upon why you're tapping the joint. But the smaller the fluid, more difficult it gets, and the more viscous it is, more difficult it will get to aspirate. So you just have to choose the shortest length of the needle, the widest gauge of the needle. So it is easier to aspirate that way. But without knowing what the clinical scenario is, it may be difficult to say anything further.
Perfectly said. And just to add, as sir said, the smaller the fluid, the bigger is the problem. So that makes it even more important to know why you are doing it, so that if you have very small amount of fluid, your main clinical suspicion, that should be the one test which you should do. So the next question is, which position is preferred for scanning the left elbow of the patient?
Oh yeah, so these things are much better in our hands-on workshops. So you see, there are so many things, and I don't want to get going because I'm eating the time of Elena here. But there is a different way you do right shoulder. There's a different way you do left shoulder, and all of these, more than patients, is to save yourself. Because if you're doing this day in and day out, you want to do it in the most ergonomically easy way for your own joints. So if that is the case, there's no way to tell this in didactic lecture, but we will show in the workshop how would you do that to save yourself and how the convenience of the patients. So yeah, it's tough to explain, but I will show when we can in a live workshop.
Perfect. Thank you for the answer, sir. And just to highlight here, we have a one whole day of MSK Ultrasound hands-on workshop in Mauritius on the 27th of September. So it is Fridays MRI workshop, Saturdays ultrasound workshop, and Sundays interventions workshop. And this time we have divided the workshop into both basics and advanced. So there will be a basics live demo of each joint, advanced live demo, and the basics and advanced combined hands-on sessions, wherein there will also be a interactive lecture on the pathologies of each joints. So you can find, so we are going to look at every possible advanced structure. Like in wrist, we are going to evaluate TFCC, the sagittal bands, right from basics to most advanced. And we also have a session on peripheral nerve ultrasound, wherein we will see the common nerve lesions, the normal common nerves that you have to scan, and we'll be looking at the pathologies also. And the icing on the cake is on each day we have a very interesting quiz, and we will have attractive prizes, which will be including great MSK radiology books. And also the winners of all three quizzes will get to publish papers with the faculty of the event. Next, we are moving on to Dr. Elena for her lecture, which is going to be iatrogenic nerve lesions, which can be diagnosed with high level of confidence on ultrasound. Dr. Elena Drakonaki, she is the MSK radiologist practicing in Greece, and she is assistant professor in the medical school of University of Crete in Greece, in the Department of Anatomy. So she is a musculoskeletal radiologist who is a lot into teaching musculoskeletal anatomy and has an association with the University Hospital with the Department of Anatomy there. She is also the current vice chairperson of ESSR. Dr. Elena, over to you.
Hello. Thank you for this invitation. I'm really looking forward to the Mauritius event. Going forward, after this excellent comprehensive talk by Professor Girish, I'm going to focus on postoperative and iatrogenic nerve trauma. So, can you see my screen? Yeah?
Yes, we can see and hear
You
you.
can, yes. So, postoperative iatrogenic nerve trauma. Iatros in Greek is the word corresponding to the word doctor. So, iatrogenic nerve trauma is every nerve injury which is caused by medical procedure. So there is a lot. There are a lot of such injuries which are covered within the list of complications of many procedures, surgical procedures which are performed around the joints, and there is a specific risk for a specific nerve which is associated with each of those specific procedures, and this is well documented in the literature for the lower extremity, for the neck, for the upper extremity. So, iatrogenic nerve trauma is quite common. It's 17% of all traumatic nerve injuries. The most commonly affected nerves are the accessory nerve after lymph node biopsy at the neck and the median nerve after carpal tunnel release. And the most common causes are surgical repair of fractures and implementation of prostheses, as Professor Gandikota showed us previously. The management of those injuries is directly correlated to the cause, but up to half of those cases require surgery, and that is, of course, a very uncomfortable situation for both the patient, but also especially for the surgeon, because they have to operate again in a hurry and in stress because of a complication which is affecting the patient. Electrophysiology is a gold standard for imaging the nerves. However, when it comes to nerve lesions, peripheral nerve lesions, especially iatrogenic nerve lesions, there are several limitations in electrophysiology. Now, electrophysiology has difficulty in localizing injury site if there is complete loss of nerve conduction, and especially if there is selective injury of some of the fascicles inside the nerve, that may lead to false negative results in electrophysiology. And the reason is that electrophysiology measures the velocity of the intact fascicles. So if there are fascicles which are intact within the nerve and some fascicles are injured, then electrophysiology will show false negative results. Also, it can be very uncomfortable, especially if there is open wound in the postoperative period. But the most important limitation is the fact that it needs time to provide information. The information is available 2 weeks after Wallerian degeneration is completed, and the best information is provided by electrophysiology 3 months after injury. But this means that we miss the window of opportunity to diagnose the patient and take very immediate action in reoperating the patient, taking out an implant, or performing grafting. And we need to perform immediate evaluation of the patient when there is iatrogenic nerve injury, also because of medical legal issues. So we need to image the nerve lesion right away after iatrogenic injury. And electrophysiology is no good for that. On the contrary, ultrasound is excellent for that because it can be performed without delay. We can scan from day one, post-operative day one. It provides excellent spatial resolution of the lesion and of the nerve. It is possible in cases of pain, it is painless, and that's why it's possible in open wound situations. It is not limited by metal implants like MRI, and it provides excellent localization of the lesion site and assessment of the continuity of the nerve, and also it allows us to find the cause. Compared to MRI, it has the same specificity, but better sensitivity. And the reason is that it is not limited by metal implants and is not limited by spatial resolution. So ultrasound is very important for iatrogenic nerve injury, and it has been shown by papers that it can change the therapeutic management decision in up to about 60% of cases, which is very important for the patient and also for medical legal issues later. We know that ultrasound is amazing for imaging the peripheral nerves. It shows the characteristic honeycomb appearance of the nerves with the echogenic supporting structures of the epineurium and the perineurium and the hypoechoic nerve fascicles. Using a new linear probe technology, we have high-frequency probes and ultra-high-frequency probes. And using these probes, we can see very high-resolution images of the nerves. We have improved delineation of the fascicular borders of the nerves and the bundles of the nerves. And we can also see features of the nerve in close correlation to histology. For example, we can see intermingling of the fascicles, which was described back in 2003, but now we can see it using ultrasound. And also we can see the vasa nervosum inside the normal nerves. And also we can see the very small cutaneous, mono and oligofascicular nerves in a very superficial area of the just under the skin, less than 5 centimeters from the skin. And these small nerves might be clinically important. So what is important to look for when we look for nerve injury? It is important to look at the site of the nerve and look for enlargement of the nerve in cross-sectional area, but also we have to look at the individual fascicles inside the nerve, because in some cases we can have fascicular damage, so selective damage inside the nerve, so we have to look inside the fascicles as well, not only the nerve as a whole. We need to look at changes of the echogenicity of the nerve, whether there's edema, so lower echogenicity. We need to look at the echostructure of the nerve, whether it is preserved or distracted. And we need to look at the surroundings of the nerve, because in many cases, the solution and the cause of the problem is lying at the surroundings of the nerve. As a rule of thumb, from proximal to distal, the nerves become more echogenic because the amount of connective tissue increases, and they become smaller because of branching. So whenever this rule of thumb is not happening, we need to look further and inquire further, because there is something wrong there. And also we need to look to expose the whole of the limb when we want to scan for a nerve area, because we need to go distally and proximally with our probe, so we need to have all the limb exposed. We need sterile conditions if we're dealing with open wound, especially in the post-operative period, and we need to have multiple probes available to look for superficial and deeper areas, because the nerves change position as they move at different areas. And we also need to document everything in videos and archive everything, make sure that we archive it, because this condition may have legal implications possibly, so we need to have everything archived. What is most important about ultrasound is that it allows us to look at the continuity of the nerve and differentiate between total nerve transection or type 5 of Sunderland injury from preserved continuity of the nerve, so types 1 to 4. And we have this kind of classification. We'll know about the Seddon and the Sunderland classification of the nerves. And there are typical ultrasound patterns which correlate with these type of nerve injury. In neuropraxia, which is the lightest type of injury, just edema of the nerve and of the nerve tissue, but without any transection of the nerve, there are no ultrasound abnormalities at all. We might see completely intact fascicular pattern, and that carries a very good prognosis with conservative treatment, so the patient becomes much better later on. In axonotmesis, which is Sunderland type 2, in very mild cases of axonotmesis, we can see enlarged cross-sectional area of the nerve, but also of the fascicles inside the nerve. So some nerves can be enlarged and some can be normal because of edema, which can be either as a whole or a selective edema inside the fascicles. As the axonotmesis level becomes more severe in Sutherland type 3 and 4, we have, of course, axonal disruption, but we also have endoneural and perineural disruption. So in these cases, the higher the degree of loss of normal architecture we see, the poorer the prognosis. So ultrasound is associated with the prognosis. If we have a very distorted nerve, then we know that the prognosis will be poorer than in cases where the nerve is just slightly distorted. In significant axonotmesis, Sunderland type 4, the nerve can form an internal wall of fibrosis through which the axons cannot regrow. And if this happens, the axons cannot regrow and go forward, but they stay there and they create a large disorganized swelling at the area of the lesion site, which is called neuroma incontinuity. And we can see multiple neuroma incontinuities in this case, which was an injury with a knife. And this is another case of neuroma incontinuity because we see that there is continuity with the fascicles, but here there is a disorganized swelling at the lesion site. In axonotmesis or Sunderland type 5, there is total transection of the nerve, total loss of continuity. So everything is torn. The ends recoil and retract because the nerve is in tension, and when it is cut, the nerves recoil and retract, and this causes malalignment in the axis of the nerve. So, in other words, we might find the nerve in a slightly different position of its true anatomical position because of retraction and recoiling. And the regenerating axons at the stump, they create a stump neuroma. And this type of injury is very important to be identified using ultrasound because it needs surgical repair with resection of the scar tissue and some cases with grafting. And you can see the stump neuroma here and the transection here with the recoiling at this area. We can also have a typical ultrasound patterns of nerve injury, so patterns which do not fit a specific pattern or heterogeneous lesions. For example, we can have intact fascicles together with distorted fascicles within the same nerve, as in this case. This was a median nerve at the forearm, and it was injured with a knife, and as you can see, with a surgical knife, but here you can see that some of the fascicles are distorted, some of the fascicles are okay. And we can also see intraneural hematoma or fibrosis, which carries very poor prognosis. For example, in this case, where there is hematoma inside the nerve. In the postoperative setting, the injury of the nerve can happen because of various mechanisms. And we can have direct injury of the nerve because of cutting instrumentation. We can have entrapment of the nerve by metal implants or scars. We can have mechanical factors influencing the nerve, for example, stretching or traction, or because of positioning of the patient during the operation, positioning of the patient for the operation. We can have ischemia of the nerve or toxicity of the nerve because we injected a solution to wash, for example. And all of these mechanisms can create damage of the nerves either at the surgical bed itself or in some cases away from the surgical bed. And let's see some cases to illustrate these mechanisms. For example, we have a 60-year-old male. He had fracture of the radius and ulna. He was treated with internal fixation. And just after the operation, he woke up and he presented with finger and wrist drop. The clinical presentation was typical of posterior intraosseous nerve injury. But what was the cause in that case? And let's see this video. So here you can see the nerve. Here is a nerve entering the supinator canal, and here is the metal implant. So the nerve is not seen because of the metal implant, and then we see the nerve again at the exit of the canal here. And it's normal again. So again, this is a long axis view of the nerve. This is the posterior intraosseous nerve, and it's underneath a metal implant. So we reported this case as a transection or a disruption of the nerve because it is stuck underneath a metal implant. So the patient was directly operated the same day. There was surgical exploration. They found nerve transection. They removed the metal plate and they grafted the nerve. And that happened the same day. MRI would have been impossible in this patient, and also electrophysiology also impossible. And you have to take into consideration that everyone was super stressed because this was a child. He was 16 years old, and there was severe medical legal issues. Another case of a 60-year-old male with fracture of radius and ulna, exactly the same clinical scenario, But here again, we have a posterior introsseous nerve injury after the implementation of devices, and that's the video of the posterior introsseous nerve, and you see that the nerve here inside the canal, it is there. It's not transected, but it is huge. It is very, very big. And all the muscles around are very hypoechoic or hyperechoic because they have hematoma or edema. So the nerve is huge and the muscles around are hyperechoic because of hemorrhagic infiltration or because of edema. And we asked the surgeon for clinical information, and the surgeon admitted that the operation had very long duration because they had difficulties in putting in the devices, the fixation material, and they were very worried about that. So we reported this case as nerve edema because of manipulation during insertion of the devices and muscle hematoma, no transection of the nerve. So they did not operate this patient. They waited based on our report, and indeed the patient did well many weeks later, of course.
There is a, sorry to interrupt, there is a in between sometimes some disturbance with your audio.
Okay, so do you need me to go back?
Yeah, maybe just the last slide.
So I wanted to say that in this case, we reported this case as nerve edema because of manipulation during insertion of the device. So the patient was not operated. They followed them up conservatively. He took conservative treatment with drugs to reduce the amount of edema, and he became better later on. So in this case, because of the ultrasound report, they did not have an operation the same day or the next day. Another case of a 44-year-old woman, she had fracture and she had metal fixation and at the level of the forearm again, and she had very strange numbness during pronation and supination of the forearm. And what we found in ultrasound is that the median nerve of the forearm was impinged and there was friction of the nerve on the metal plate. And that's why she had this very strange pins and needles while she was doing movements with her forearm, and especially pronation and supination. So that was a case again where she had a reoperation. Another case of post-carpal tunnel release, the patient had symptoms getting worse after 5 months, and ultrasound showed the presence of scar tissue encasing the nerve. And using dynamic ultrasound with movement of the fingers, you see that the nerve is stuck. It is not able to move under this scar tissue. And again, the patient in that cases had steroid injections inside the scar tissue in order to try and create atrophy of the scar tissue. Another case of Decker vein stenosynovitis release. The patient had Decker vein stenosynovitis. They had release, surgical release, and after the surgical release, the patient said that the symptoms were different. They still had symptoms with numbness of the thumb, but different types of numbness. And we scanned this patient, and we found out that the superficial branch of the radial nerve was entrapped in scar tissue, and that's why the patient was treated for the Decker vein stenosynovitis, of course, but they ended up with chiralgia paresthetica, which is a condition because of the injury of the superficial branch of the radial nerve. This is the branch. It is an oligofascicular nerve of 2 fascicles. Other cases of mechanical factors that could injure the nerve because of positioning of the patient or stretching or traction of the nerve. And in those cases, the injury is away from the surgical bed, at the area where the nerve is fixed or anchored at fascias or bifurcations. This can happen because of skin retractors or manipulation during implantation of implants, and this has very good prognosis with conservative treatments. How do we realize that this is happening? The patient comes with symptoms of a specific nerve, and the surgeon says that I did not operate near that nerve. I didn't see the nerve at all while I was operating. It was a completely different area where the operation happened. This is a red flag that tells us that we have to scan proximal to the level of symptoms. For example, this is a case that illustrates this condition. This is a young female. She had internal fixation because of a femoral fracture. And immediately after the operation, she had foot drop, a typical condition because of common peroneal nerve palsy. The surgeon said, I did not operate near the peroneal nerve and I did not operate near the sciatic nerve. Because the way that they put the device in was from a different area of the hip. And indeed, the common peroneal nerve was scanned at the level of the fibular neck. It was completely normal. But when we scanned more proximally at the level of the sciatic nerve, we saw that the sciatic nerve of the affected side compared to the asymptomatic side was different. And the division of the sciatic nerve, which distally became the common peroneal nerve, had two very big fascicles inside the nerve, whereas the other side had normal fascicles. And also the tibial division had bigger fascicles than the other side. So all the nerve was bigger, but especially the peroneal division was much more big compared to the tibial division. That was a case of sciatic nerve damage because of intraoperative traction, elongation of the nerve, which can happen in up to 2% of cases. And the peroneal division is more susceptible than the tibial division because it is more superficial and it is fixed at the sciatic notch and the fibula head. So it is easier to be elongated because it is fixed at both areas. And this condition has very good prognosis. In the differential diagnosis of this position is common peroneal nerve damage of the nerve itself, of the common peroneal nerve itself, because of compression of the common peroneal nerve on the bed, because they put the patient to the side in order to put the material in, and while putting the patient to the side, the calf supports all the weight of the leg because the fractured femur cannot provide support, so all the weight goes on the calf, on the fibula, and this can cause compression of the common peroneal nerve. That was not happening in our case because in our case the imaging showed the normal common peroneal nerve, but all the injury was because of elongation of the sciatic nerve. So, in conclusion, I would like to point out that targeted ultrasound investigation, together with very good clinical knowledge and collaboration with the clinical doctors, the surgeons and neurologists, can give solutions to clinical challenges and difficult situations in everyday practice in a setting of iatrogenic nerve injury. It can help us identify the lesion site and assess the continuity of the nerve. It can help us scan in the acute phase of trauma, so it can help us have a window of opportunity to diagnose the patient and treat the patient very quickly if surgical treatment is needed, in order to minimize the possibility of medical legal issues at a later stage. And also, it allows us to determine the management of the patient and the prognosis of the patient. And if you are more interested about postoperative and iatrogenic nerve lesions, you can look at this paper, which is quite recent, 2024, and it illustrates all of these conditions in detail with very nice and very interesting cases. Thank you for your attention, and I would like also to invite you to the ESSR in Toulouse next month for an MSK for MSK cases and MSK people to meet. Thank you for your attention.
Thank you, Dr. Elena. I think that was a wonderful talk. And post-operative imaging, iatrogenic injuries of nerve are real, clinically very important to evaluate and sometimes can be tricky. So I think that made everyone who's listening their task easier. There are a couple of questions. One question is, can we use the Sunderland classification on ultrasound and say whether it is grade 1, grade 2, or grade 3 injury?
And let me see the question again. Where is it? Can you explain how to differentiate Sunderland? Okay, so in Sunderland type 1 is just neuropraxia. Neuropraxia means that there is just loss of nerve conduction, so functional problem of the nerve, but no anatomical problem. So in that case, you see nothing in ultrasound. So if you have a clinical situation when there is evidence that there is functional nerve issues, but nothing seen on ultrasound, and if you are sure that you have done a very thorough test, then it's probably neuropraxia. But you have to be sure that your test is thorough. You have to be confident on yourself and very experienced. So that is neuropraxia. And in Sunderland type 2 and 3, which is quite low level of injury, you see the nerve, you see the epineurium of the nerve, you see the borders of the nerve, you can see fascicles inside the nerve, but you can see either enlarged fascicles or hypoechoic fascicles or fascicles which are blurred. So you cannot see them very nicely. The borders of the fascicles are very blurred, are not well circumscribed. And that is type 2 or 3. Sometimes you cannot say whether it's type 2 or type 3. But it's not important because both type 2 and 3 have conservative treatment. So for the neurologist and for the surgeon, type 2 and 3 is the same. It means just conservative treatment. The only difference lies in the time needed for the patient to become better. So in type 1, so neuropraxia, the patient becomes better and everything resolves within a few weeks, like 1 week or 2. But in type 2 and 3, they might need more time. And that the time cannot always be determined, but we know that it might need more time. That's the only difference. But in terms of findings, in terms of imaging findings, type 1 means no findings at all. Type 2 and 3 means mild findings with an intact outer border of the nerve. I hope I answered this question.
Yes, thank you. Last question is, does ultrasound have a role in evaluation of diabetic neuropathy and inflammatory neuropathies?
Yes, it does. But this is a completely different topic. So we're going to talk more about that when we meet at Mauritius. It definitely has a lot of indications in inflammatory neuropathy, especially. And neurologists have now started performing their own ultrasound, and there are a lot of papers in the literature. In diabetic neuropathy, there are less indications, but still there are indications there, especially after operations, and especially if there's carpal tunnel syndrome in the setting of neuropathy. So we can talk about that when we meet in Mauritius, but yes, there is a lot of work there.
Right. I thank Dr. Elena and Dr. Girish for taking out time to educate us all. And just a couple of words about Mauritius. So this is the second edition of the event, International Musculoskeletal Summit. The dates are 26 to 28 of September. As I said, there are 3 different workshops. This is the website, mskis.org. There are 3 different workshops on Friday, Saturday, Sunday, ultrasound interventions and MRI workshop. And these are all hands-on workshops. There is an option to register for only ultrasound and interventions workshop, or you could register for all 3. What is important is if you're planning to attend, then probably tomorrow and day after tomorrow are the best days you can register for it, because we will be closing the first early bird on the 15th. We have extended it because there was a technical issue in the registration on the website. So we extended by a week, which is good news. So I hope to see a lot of you there. And what we can promise is, Dr. Elena, can you give us 2 reasons why everyone should come to Mauritius?
2 reasons. I think just one is okay. Well, yes. I would say because there will be a lot of practical information and practical tips and tricks delivered by all of the faculty, because all the faculty is very experienced. We have a lot of experience in real life, and I think this is what we really need to teach what is happening in real life. So it's going to be a really practical, let's say, workshop, and also because Mauritius is a nice place to go. That's the second reason. Yeah.
Yes, Dr. Girish, just like you to add closing words and.
Yeah, hey, Gauri, you can hear me?
Yes.
Okay,
Yes.
good. So I have been to Mauritius, guys, and it is the most beautiful place. So there's only one reason, and it is to come with family, enjoy, and while you're there, get some CMEs. And as Elena was mentioning, you will get a lot of lectures out there on all these topics. But what you will get from us is the practical experience of 15 or 20 years. Just like you asked, how do you do left elbow versus right shoulder, or how do you deal with this nerve lesion that I see? That you may have your own set of questions, and you will have the time to talk to us, and we will learn from you. You will learn from us. It'll be beautiful in a beautiful background, Mauritius. So I think the first reason you should see that place is beautiful. Thank you.
Right. So it's a mesmerizing backdrop to have a conference in, and I hope to see a lot of you there. And as both
Mhm.
of them mentioned, it is going to be a lot and lot of clinical teaching with a lot of practical pearls, and we are going to uh, include a little bit of clinical examinations in the ultrasound workshop too. So it's going to be a very different flavor of MSK hands-on workshops of what you have seen so far. So I thank you all for your attention, and we have our last webinar, which will be on MSK interventions on the 27th of June. We'll be sending out the informations to all of you very soon. Thank you all for your attention, and if you're planning to come, do register by 15th. Otherwise, the first early bird ends. Thank you. Thank you, Dr. Elena. Thank you, Dr.
Thank you.
Girish. Thank you,
Thank
everyone.
you. Bye-bye.
Thank you.
Bye.
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 Bye.